All right, well, welcome everyone to our session today. We are honored and excited to be hosting Professor Edwina, who will be speaking on establishing goals of care to maximize quality of life at end of life for our patients. And we are Africa Healthcare Network, and we are offering these webinars or fireside chats, as we call them, on a weekly basis. And once a month, we get a chance to host supportive care or kidney supportive care topics. My name is Erin Das, and I'm a palliative care nurse originally from Canada, yet I live and work in Kenya. I'm really excited to be part of the team. Tonight, we are welcoming, as I mentioned, Professor Edwina Brown, and she will be here with us for this next hour. She's a consultant nephrologist at Imperial College Healthcare NHS Trust in London, UK. And she is the president of the International Society of Peritoneal Dialysis. She's co-authored 2 books on renal supportive care and has had over 200 publications, which mostly focus on peritoneal dialysis, outcomes of older people with advanced kidney disease, as well as renal supportive care. She currently is studying and focusing on kidney transplant in older people. And she's the principal organizer of the annual Supportive Care for Renal Patients meeting that happens in the UK. She's co-chaired a work group at the KDIGO Controversies Conference on Supportive Care and Chronic Kidney Disease, which happened in 2013, and also co-chaired the KDIGO Controversies Conference on Symptom Control in Dialysis more recently in 2022. We are really excited, as we were just chatting before, getting to know one another a bit more. Really excited for you to be here and speak to each of us today. So welcome, Professor Edwina.
Well, thank you for the invitation to speak to everybody here. I look forward to learning as much from you as I think I'm going to be telling you. So let me just get up my slides. So this is the topic I've been asked to talk about. And those are my disclosures. Usually when I talk about this, and the reason I got into this topic here in the UK is because of the increasing number of older people who now get advanced kidney disease and are on dialysis. But of course, as I was preparing this talk, I realized that actually things were very different for this particular audience, because it's much more the fact that dialysis is not very much available in many parts of Africa. And this is shown in the Global Kidney Health Atlas here. And the sort of paler the orange you are, the less dialysis you have, which means that many of the people who are needing supportive care are going to be much younger. But aging is happening in all societies, and even though you may now not have many older people requiring supportive care, I was being told that the age range is mostly from 16, maybe up to 70, whereas in the UK, US, it's much later. In all countries, there are aging populations. And this graph was put together by one of my colleagues, Richard Corbett, when we were writing a chapter about PD in the older person. And he went through different registries and databases and has shown that in all countries, and the orange one here is Malawi, you can see that there's a rising life expectancy, though obviously it's behind the Western countries. It's not going to be long before there's catch-up. So what are the implications of the diagnosis of advanced kidney disease? And let's think about it from the patient perspective. And I rather think it's like going into this tunnel. So this is a wonderful painting that I saw at an exhibition in New York by somebody called Edward Hopper, who painted in the early 20th century. And we all know what it's like because we've seen many patients developing advanced kidney disease and having to consider dialysis treatment. But for the individual, it's leaving the brightly colored what they know into what is the complete unknown, and that is frightening. So the implications of the diagnosis for the individual is that, first of all, they probably feel lousy because particularly in countries where there's not much health infrastructure, people will tend to present late with their kidney disease. So they're very symptomatic and probably uremic. There's fear about dying. There's fear about whether they'll be able to continue working. There's fear about all these unknown treatments, dialysis, transplant, fear about whether such treatments are actually available locally and how much they will cost. And of course, there's fear about the impact on the family, particularly if people have to relocate so that they're living closer to a dialysis facility. Plus, if they are older, they will be having all the problems of older age. And these problems are more severe and accelerate more rapidly in people on dialysis than they do in the general population. So I don't know how many of you are familiar with this book by Atul Gawande. He's a urologist, works at Harvard, and he does, but he's also a medical journalist. He wrote this book about 10 years ago, and I use it. First of all, I tell all my students and trainees that this is really compulsory reading. But here's just one of the quotes. Medicine's focus is narrow. Medical professionals concentrate on repair of health, not sustenance of the soul. For more than half a century, we have treated the trials of sickness, aging, and mortality as medical concerns. That experiment has failed. And that really underlies the concept of supportive care. So supportive care or palliative care is something that should be introduced as part of care of any long-term condition, and particularly kidney disease, alongside curative treatment and interventional treatments. And as time goes on, as people become more sick and the curative treatments become less effective, then the amount of supportive care increases until you're getting near the end of life, when you really focus entirely on palliative care or hospice care, and then move on to bereavement. So thinking about end-of-life decision-making, which I certainly always encourage my patients to start thinking about it really almost as soon as they start on dialysis treatment, particularly if they're older and they've got other comorbidities. And the things that they need to think about is, am I actually going to start the treatment? So here's somebody with advanced kidney disease, declining health, poor prognosis. Is starting dialysis actually going to be of benefit to them? So, and it's often not starting the treatment is the conversation one would be having at this time. And if they do start the treatment, moving to the phase where they're becoming sicker, older, and one needs to start thinking about discontinuing or withdrawing the treatment, and then end-of-life management. And all of this is to try and achieve a good quality death. So this was something that was, people made an effort to actually define over about 15 years ago in the UK. So this is the section from the End of Life Care and Advanced Kidney Disease that was published by the Department of Health in 2009. And they said that the characteristics of care during the last days of life, which are important from the patient's perspective, are receiving adequate pain and symptom management, avoiding inappropriate prolongation of dying, achieving a sense of control, relieving the burden on loved ones, and strengthening relationships with loved ones. And how do you achieve this good quality death? And that's through patient-centered and supportive care, being realistic awareness of life on dialysis, enabling people to know what the prognosis is, recognizing when people come to the end of life, communicating through advanced care planning, and thinking about the last few days. This has been really looked at in great depth by the International Society of Nephrology, the ISN, and they came up last year, well, or this year rather, with the curriculum for kidney supportive care, which was launched at the WCN meeting in Buenos Aires. And this diagram comes from their paper that was written by Sarah Davison in Kidney International. So in Western countries, we talk about, here's your patients who are going on thinking about kidney replacement treatment. They have shared decision making and go on to either one type of dialysis modality or have a transplant, or they decide they're not going to have dialysis and have conservative care. And the proportion of their care which is provided by kidney supportive care is illustrated by the green part in each block. But on the right-hand side of this is what happens in countries where there's people can't access medical care, or kidney replacement treatment is not available. So you then have untreated kidney failure and undiagnosed kidney failure. And they have what has been called choice restricted. So they're not choosing to have no dialysis or conservative care. It is almost being sort of forced upon them because there's no other alternatives. So thinking about maximizing quality of life at end of life, I've decided to really focus on the shared decision making, the conversations of not starting dialysis, the conversations of discontinuing dialysis, and then thinking a little bit about supportive care. So shared decision making is quite a complex thing. It's not a one-off conversation. It's something that you build up over quite a few interactions between the patient on the left-hand side and the service or the healthcare team on the right-hand side, and it says health practitioner, so that would include the nephrologist, the nurses, counselors, anybody else in the healthcare team who give information to the patient about what the actual treatment is, talk about outcomes, etc. And then eventually, and try and learn something about the patient. So the patient needs to think about what are their values, what's their experience, how do they want to live their life, and they get information from other patients, they get it from healthcare teams, they can get it from the internet, and then eventually, between all of that, you end up with some sort of shared decision. To add complexity to all of that is the fact that in all countries now, but particularly with so much migration happening really everywhere, people from different backgrounds, different social groups, different cultural groups, different religions moving, often because of war or because of economic reasons. These all have impacts on how we make decisions. But it's not just the individual patient, as shown on the left, on the right rather, sorry, with their beliefs and values and ethnicity and what the healthcare system is and what their experience is, but also the healthcare team. And certainly where I work, only 40% of patients on dialysis in my unit are actually white British. People come from all over the world. I think somebody once did a study and thought there were about 100 different languages being spoken amongst our dialysis population. And of course, the people who work in our healthcare teams also come from many parts of the world and have, again, their own religions, their own spirituality, beliefs, etc. So what is the sort of information that we need to share when considering dialysis choices. So as part of the shared decision-making process. So as the healthcare team, we want to know about the person's lifestyle. What do they do? Are they working? Do they travel? Who do they live with? Where, etc.? What's their social support? And what are their goals? What's important to them? Is it quality of life, length of life? Is it being able to continue working? Is it able to travel? Is it because they're caring for other family members? Is it because they want to go live to a special event, like see the graduation of a grandchild or a wedding or something? We as the healthcare team have to inform the patient and their family about what's the prognosis. When do we think kidney function will decline to the stage that they may need dialysis? What's their realistic life expectancy with and without dialysis? So an unbiased, realistic information about pros and cons of different types of dialysis. We need to tell them what would happen if they have active medical management without dialysis or conservative care. And we need to be honest with them about what the trajectories of things like physical function, symptoms, cognitive function would be with and without dialysis. And we need to tell them what supportive care is all about. And then we come up with a decision. I thought it'd be just worth reviewing what was decided at the KDIGO Controversies Conference on supportive care back in 2013, what comprehensive conservative care is. And that is really all the management for people that with CKD5, that includes symptom management, trying to slow down rate of progression, etc., social and family support, but it does not include dialysis. And we were very clear in that discussion that this is what people choose rather than being forced on them because of no supply of dialysis. It's also difficult to know when you should start having these conversations. If you do it too early, it just increases anxiety and depression in patients and families. It may increase the choice of conservative care, as it's natural to say, if I asked any of you on the call, do you want dialysis? I'm sure you'll all say no, but that doesn't mean that when you actually get to the stage of needing dialysis, you would not say something different. If you leave it too late, then, as we all know, there's a much worse prognosis with acute start. There tends to be a default to in-center hemodialysis rather than planning for peritoneal dialysis. And people wanting conservative care may well be pressurized by their families onto dialysis because they're now become very symptomatic. So let's move on to the other part of the spectrum and think about what are the conversations if you're discontinuing dialysis. So why is dialysis discontinued? Well, socioeconomic reasons, money runs out, and that affects both the patient and the family. In countries where there's not free supply of dialysis, as happens in the UK National Health Service, there's the burden of dialysis, and that can particularly include travel distance if there aren't many dialysis centres. Then, of course, you get the complications of dialysis. You may run out of vascular access. You may not be getting sufficient dialysis and you become uremic. You can get many other major complications, severe peritonitis and PD, or endocarditis and hemodialysis. General deterioration in health, either acute or chronic, often related to comorbidities such as cardiovascular or infections. And then in most series in the West, there's patient preference. So people decide they want to stop dialysis, and that accounts for about 30–40% of people who are discontinuing dialysis. And this is just a study that was done in Europe that shows that the size of the circle shows the number of people in a given center stopping dialysis. But stopping dialysis becomes more likely if you're working in countries which have a fairly permissive attitude to stopping life-sustaining treatment. So when should we have these conversations about end-of-life wishes? Do you want, explaining to people that time is short, that this is now time when we should think about, do they really want to have resuscitation? Do they really want to have that operation? Do they really want to have a chest infection treated, etc.? Do they want to die in hospital or at home or in a hospice? So people are coming towards dialysis, and older people or people with major comorbidities, they've got a failing transplant and the person doesn't want to restart dialysis, then either failing PD or hemo and transplant not feasible, and at times of any other major event. So if somebody has a stroke, or they have a fall and a fracture, or they have a major cardiac event, that's the time when you should start having conversations. And having advanced care planning, which is really absolutely key to enabling quality of life at end of life. So communicating with the patient and family about prognosis and realistic impact of treatment, thinking about symptoms, including pain, allow time to answer all their patients' questions. These conversations are never quick. So it's important to plan ahead to enable people to achieve their goals and acceptable ceilings of care and place of care. And they need to be done, as we've already discussed, in a culturally sensitive way to be attuned to the needs of the patient and family. Does it work? Well, there are now a number of randomized controlled studies, including in hemodialysis, but I've actually chosen just to highlight one of the first randomized studies looking at advanced care planning, which was done in elderly, just general medical patients, and was published in the British Medical Journal a good few years ago. So this was over 300 patients randomized to advanced care planning or not, and 56 of those patients died within 6 months. And they found that advanced care planning improved end-of-life care, patient family satisfaction, and reduced problems in the surviving relatives. And these are just some comments from family members and who were interviewed in the intervention group after their family member died. So we had a clear plan, so could just relax and enjoy time with Dad. We felt really comfortable making decisions because we had discussed it with him, etc. And then he should have had more say. These are the ones in the control group. They wouldn't let her go. They kept doing tests and things she would not have wanted, etc. So this all sounds very simple, but as we're all aware, there's lots of barriers to shared decision making, and we need to think of possible solutions. And I've really adapted these tables from what I wrote with Peter Blake from Canada in terms of shared decision making for people on peritoneal dialysis. So in terms of the actual person with advanced kidney disease, it can be difficult to have the conversations because they may be in denial. I have many patients who decide that the easiest way to cope with the thought of needing dialysis is just to stop coming to the clinic, and that way the kidney disease will disappear. And of course, unfortunately, that's not what happens, and they end up by presenting really late and with problems. Cognitive impairment is common in this group of people, much more common in people with on dialysis or with advanced kidney disease than in the general population. There's often limited health literacy, general poor attainment in education or low attainment in education, and therefore not really understanding medical things. People can be depressed or anxious, and that makes it difficult to make decisions, or they may come from a different culture to the primary national one. And of course, if people do present acutely, there's limited time. How can we solve these various problems? As I've said, shared decision-making is not a one-off conversation. That is overwhelming for people, and they really can't take in everything that you're saying. So it's small amount of information at a time. Really try to avoid using jargon so that people actually understand what you say, repeating what you're saying several times, summarizing what you say, give information in different ways. Some people have access to the internet. Some people like videos, some people like reading, some people just want talks, and giving some psychosocial support. But what's really important is to train the healthcare team how to have these conversations, etc. So over and above problems with the patient, there's also issues with the healthcare team itself. Many are uncomfortable with sharing bad news. There's a lack of confidence to talk about palliative care, and also we as healthcare professionals often have unrealistic expectations of what our treatment is going to offer, and unrealistic expectations of prognosis. So people really benefit from communication skills training, and again, multidisciplinary meetings to discuss individual patients. And then the whole system, does it really support people for shared decision-making? Often where we work, there's little privacy in either outpatient or inpatient settings. There's a lack of continuity. People are being seen by multiple teams and members of that team, so all tending to say slightly different things. So we really need to think about how we record these conversations, and really as a team think about how we all say the same thing. So finally, moving on to supportive care. This was defined by the UK National Council for Palliative Care as the care that helps patients and families to cope with the condition and its treatment from pre-diagnosis through diagnosis and treatment to cure, continuing illness or death, and into bereavement. It helps patients maximize benefit of treatment and to live as well as possible with the effects of the disease, and it's as important as diagnosis and treatment. And this is just a diagram of what supportive care or kidney supportive care looks like. When people present, you start with aggressive treatments, slow down the rate of progression of kidney disease, thinking about kidney replacement therapy, which require any interventional surgeries, giving antibiotics for infections, etc. But as time goes on, and people are moving along the pathway, the natural pathway of their long-term condition, i.e. kidney failure, towards the end of life, then things like pain control, symptom control, psychosocial support all become more important. Being aware of people's goals and concerns, and thinking about advanced care planning. So who should be delivering this these conversations? So this concept of primary palliative care and specialist palliative care came from an article in the New England Journal of Medicine, which was published just over 10 years ago. So primary palliative care consists of basic management of pain and symptoms, basic management of depression and anxiety, and basic discussions about prognosis, goals of treatment, etc. Whereas specialist palliative care focuses on things like refractory pain, management of more complex depression, assistance with any conflict resolution regarding goals between families or between staff and families, and then the care that people need towards the end of life. So I would like to suggest that the nephrologist should be the primary palliative caregiver for people with advanced kidney disease. palliative care should be an integral part of what we do as a nephrologist, that we should regularly discuss prognosis as both part of pre-dialysis care and as part of standard dialysis care, and that we should regularly attend CME events like you are at the moment on palliative care. And I'm delighted to see that AHN does monthly webinars on supportive care. It is so important. And the skill set really is as we've already talked about. We, as nephrologists, we should know about basic management of pain and symptoms, basic management of depression and anxiety, and we should be able to have discussions about prognosis, goals of treatment, suffering, and resuscitation status. The number of symptoms that people have with kidney failure has been known for some time. So this was one of the first descriptions of the number of symptoms. It was published about 20 years ago from the US. And as you can see, people with kidney failure have multiple symptoms. And this is associated with depression. And we need to be aware of this. And at the recent KDIGO Controversies Conference on Symptom Management, we identified many symptoms that affect patients. But we can't manage all of these. The important thing is to really try and work out with the individual what is the key symptom. So clinicians should assess and focus symptoms that are most important to individuals, that this should be done by both doctors, nurses, everybody else on the healthcare team. Ideally, we should just ask an open-ended question that explores patients' priorities. So I often say to people when I first see them in the clinic, how are you? What is bothering you most at the moment? So how do we achieve the aims of supportive care? And communication is really the most important thing. Communicating with the patient and the family about expectations and wishes, being realistic, telling people that they're coming near the end of life, doing the advanced care planning, and then appropriately managing the dialysis with discussion of withdrawal where appropriate, or not starting dialysis, and introducing advanced care planning, and which we've already discussed. But really, this is really important in all decisions that people have to make at this stage. Do they want dialysis? Which type of dialysis? Do they want to continue with dialysis or stop it? And each time that somebody suggests another invasive treatment, such as coronary artery bypass grafting or anything, related to comorbidities, to have a conversation about whether to proceed with this or not. And as part of these conversations, one should be aiming to establish what is the goal. Does somebody want to travel? Not just for holidays, but to go and visit other family members? How are they going to achieve that? Are they wanting to live for a child's wedding? There's no point in, if their goal is to get to a wedding in 6 months' time, to impose on them that they're going to have heart surgery in 3 months because they're never going to make that wedding. And it's really, as I've said, so important in terms of enabling quality of life at the end of life. I thought it would be just worth reviewing what I said earlier on about what is a good quality death. It's receiving adequate pain and symptom management, avoiding inappropriate prolongation of dying, achieving a sense of control, and being with loved ones and relieving the burden on loved ones. So what affects dying? It's not a simple answer. There are many factors that influence the quality of dying. So communication is absolutely key. People being aware that they're in the last few days, so family members can be with them. and that they, don't have to continue dialysis during that time, that symptoms are controlled, avoiding unnecessary treatments, having conversations about place of death. Do they want to be at home, hospital, hospice, etc.? And really thinking about the impact and support that individuals and families can get from religion. And as part of that, we need to be aware that people's belief structures vary across the world. So much of the palliative care literature comes from US, Australia, and the UK, and therefore focuses on the concept of patient autonomy. But I'm very aware that in many parts of the world, other healthcare beliefs are more important. There's the concept of filial piety, where you want to do everything possible for parents. There's the concept that what's really important is beneficence. You don't tell patients the bad news. You keep that to the family, not to the patient. And you concentrate really on what you as the healthcare professional think is best for the patient. There's religious beliefs which impact on people's end-of-life decision-making. And in many places, it's the family who do the decision-making and not the individual. So the concept of patient autonomy, as I've said, is in it's not even across all of Europe. It's really just Northern Europe. Southern Europe is very different. It involves shared decision-making with truth-telling and the best interest decisions at the end of life. So patients record the conversations, so you know that if they've said, if I'm no longer going to be, there's no chance or very poor chance of recovery, I want to have a dignified death, I don't want to go to intensive care, then that wish is followed. But in many countries, and then I'm sure in many African countries, it's actually family decision-making. And this is often linked to non-truth-telling and often linked to medical beneficence. And it really balances with patient autonomy. The concept of filial piety exists strongly in Southeast Asia. It's part of Confucian ethics, but it is present to a greater or lesser extent in many cultures. And children can be very unrealistic about prognosis and want prolonged medical interventions. And then there's the different religions. There's the concept of sanctity of life, you preserve life at all cost. In some religions, it's the Almighty who decides, and this can be quite a barrier to withdrawing life-sustaining treatment. In some religions, there's a belief in suffering at the end of life, and in others, that there's a general acceptance. I'm coming near the end, and I thought it would be useful to put in some of the questions that I use when I talk to people. So I've developed something called the annual review, but I don't have these conversations literally every year. Sometimes it's every few months, sometimes it's once, sometimes it's every 2 to 3 years. Sometimes it's just after a major event, but it's really to try and have a conversation about prognosis and what people's wishes are for when they're no longer able to make decisions. So I will say, how's your health now compared to a few months ago? Because often people just say they're fine. Do to use the surprise question. I do say to them, I would not be surprised if I asked myself the question about, would I be surprised if you were not here in 6 months' time, a year's time? Then the answer would be no. But that doesn't mean we should not have you would definitely not be here by then. It just means there is a chance you won't be here. But it does mean that we should start having conversations about what your wishes would be. And then different people make decisions in different ways. Do you make decisions on your own? Do you want to involve your family? Have you ever thought how much treatment you would want if you were very ill and unable to communicate to make your own decisions and unlikely to leave hospital and be independent? And then some people decide to stop dialysis when their health is deteriorated and they feel that dialysis has become a burden and is no longer of benefit. We don't need to mention that now, but it's something you may want to discuss later. And I think it's really important to bring up the concept of being able to stop dialysis with medical support, because people are hesitant to talk about it. And this really gives them permission to then ask, some ask at the time, what would happen if I stopped dialysis? Some people don't want to talk about it, but bring the subject up later on. And of course, there are challenges. And this diagram actually came from a paper that I only discovered today. It was on one of my emails from a Google scholar. And it's a paper that's just been published in PLOS, Global Public Health, really showing resources in lower income and lower middle income countries related to dialysis. And this particular diagram shows the number of nephrologists. So the pale grey are high income countries, so the reference, the orange is low middle income countries, and the darker brown is low income countries. And as you can see, the number of nephrologists available, so this is total number of nephrologists, is minuscule compared to what's available in higher income countries. So that really means that you need to think about how you're going to deliver the supportive care. It can't just be from the nephrologist, it has to be the whole team. And the nurses, physios, anybody involved need to be on the same page, and they need to be empowered to be able to have these conversations with patients about what their wishes would be. And really delivering supportive care, I think, is the natural extension of if we're delivering healthcare in a person-centered way. So this is my last slide to think about the good quality death. So this is a Dutch painting from the 1500s by Rembrandt, Jacob blessing the sons of Joseph. We should be enabling people to have the quality of death that they want. This shows an old man blessing his grandchildren with his son and daughter-in-law with him. Thank you. I'm very pleased to answer any questions.
Thank you so much, Professor Brown, for really holistic presentation. Really good to see as you brought the session to an end, just considering that we all do come from different worldviews and that we are sometimes taking care of patients who may have different beliefs than we do. But yeah, thank you for that. We do have a few questions in the chat. Sorry, my connection was off a little bit, so I got bumped out, but there's a question here. If there's a decision to withdraw dialysis, what will be the most effective approach to managing those symptoms?
I almost deliberately didn't go into that because I wasn't, because the drugs that are available are going to be so different than what we use in the UK, and I'm not a palliative care physician. But I think it's important to have a conversation with people about what to expect if they stop dialysis. And that's a question that I think I alluded to, that I am often asked, either by the patient themselves or by the family member. So I will tell people that, assuming that they've been on dialysis for a bit, they probably now no longer have any kidney function left. They're not passing any urine. The data is that people die within 7 days. So it's quite quick. And what happens is that they usually have 2 or 3 days when they feel better, because they don't have to go on dialysis. And that gives them time to do things with their families. So I remember, for example, we had a nurse, she was in her 40s, she had a 9-year-old child, and she had dreadful complications with both types of dialysis, and she decided that she was going to stop. And she had a party. She had a party for the 9-year-old the day after she made the decision to stop dialysis. And
Sounds meaningful.
yeah.
Sounds very meaningful, yeah.
Yeah. I remember another younger person who had to stop dialysis, again, for various reasons, and she decided to have her hair done. So it gives people the chance to do what they want, and then they gradually become more drowsy. Fluid overload isn't a big problem because they tend not to be eating and drinking very much. But of course, they may be in pain if they've got other conditions. It really depends what other comorbidities they've got. But as I said, I deliberately did not go into what pain control management you're going to use.
Yeah, in Kenya, we do have access to morphine. The other part of that question was, would we recommend that to be at home or in an inpatient facility? I think some of these things, as you know, the main focus of the conversation tonight has been around talking about that a little bit ahead of time, so that it doesn't feel like you're having to make those decisions in the moment, which can be really hard, as we just talked about also with different worldviews and values.
So it can definitely be managed at home, and that can, for many families, that's where they want their loved ones to die, and where people want to die. But it does mean that there has to be some support in terms of medications, you know, being able to actually look after somebody who, as they become less conscious and less able to do things for themselves, and support for their family. And that's really where palliative care teams become involved.
A good question here related to decision making. So in cases where there's discordance or a disagreement between the patient, what the patient would want, and what the family envisions, how can clinicians mediate effectively so that there can be a unified approach to care? Good question. Impossible.
That's a really, really good question. Well, certainly within UK healthcare, the patient index patients' wishes trump. So if somebody is saying, I want to stop dialysis, the family can't come along and say, we want it to continue. And I can certainly think of people where that has happened. And it's a matter of then speaking to the family and saying, this is the patient's, your father's wishes or whatever. But usually they come round to it. More of an issue is where the patient can no longer participate in the conversation, and may have made a decision about not wanting treatment. And then you have 1 or 2 family members who come along and don't agree with that. And it just takes time. It's a matter, again, of explaining what expectations are, what's likely going to happen, and saying that the goal of care is to provide support for your father or whatever. And I do use phrases like, we can't offer immortality. Dying is natural. Let's think about how we're going to achieve this in the optimum way.
Another interesting question, how should we approach conversations about leaving hospital care so it doesn't necessarily feel like families are being abandoned, also while respecting their choices? Sometimes home-based care, or even staying well connected with our patients, can be challenging because they can live quite far from facilities.
I think, well, what I would do is say, I will talk to, try and see what their fears are and what the barriers are. Try and communicate to any primary medical team in their neighborhood, either email them or phone up and try and speak to somebody. If I have somebody who is going home, then I would almost automatically phone and speak to the GP, and say this person's coming home, they're going to be dying. I've got a lady at the moment whose family have decided that they're going to honor her wishes about stopping dialysis when her dementia progressed. So I spoke to the GP and explained what was going on. The GP then sat down with the family and said, this is what's going to happen, this is the support we can put in, etc. So that they don't feel totally. And of course, with modern video links, then you should, you can still keep in touch with people even after they've been discharged home.
Yeah, and I wonder in some of our facilities, spending maybe an extra day with the family, with kind of dedicated time where you can sit and answer some of those questions face to face so that they are prepared.
Yeah.
Yeah. Great. Well, I'm wondering if any of the panelists have any questions. We're coming close to the end of our fireside chat for tonight, but wondering if there's any questions from the group, and if not, we'll.
Dr. Rasha, any questions, Dr. Rasha? Dr. Darvish?
I just want to first thank Prof.Edwina for approaching this very, very sensitive and very vital subject. I mean, your voice is speaking for those who cannot speak about themselves. And usually we try to avoid speaking about these very painful times. I mean, actually we run away from these times. So opening actually this box and discussing the details and the tiny discussions that you had with them and your experiences was really, really enlightening. And what I want to ask Prof.Edwina is actually, what was the most touching personal situation that you met? I mean, what was the patient that you met that was actually, and maybe were you kind of against the decision to stop dialysis? Did someone tell you that?
Never against the decision. I've been surprised sometimes when people have made the decision, like the nurse I told you with the 9-year-old daughter. I think we were all quite taken aback that she had decided to stop dialysis, but this was a really well thought through decision, and I had a really long conversation with her, and she had put things into place with a 9-year-old daughter, and that was a difficult one, but it was the right thing for her.
But did you try to convince her otherwise? Did you try, I mean, did you try to open up other doors for these people? Maybe it's out of depression or loss of hope?
No, we went through all of that and had a psychiatrist involved and everything. And she'd been talking about it with her work colleagues. She had had a miserable time on hemodialysis with 2 or 3 strokes. And then the peritoneal dialysis, she had a major leak, and she wouldn't even contemplate going back onto hemo even for a few weeks. And she was untransplantable. So it was a well thought out decision.
And what about, how does it affect you personally? I mean, us as like nurses and nephrologists, I mean, dealing with similar situations, how can, and it can actually affect us. Did it affect you? That, I mean, this is the part that we're not talking about. Witnessing these moments.
It affects you at the time, but equally, having these conversations is as important as anything else that we do as healthcare professionals. So I think, learning how to make sure that it doesn't affect your personal life is really important. And I've got a very close team, and we do debrief with each other, and that provides a lot of support as well.
Yeah, I mean, I think that those who will be involved in the palliative care need themselves support. I think, yeah, so that's good that you have. Thank you so much, Prof.Edwina. It was a pleasure, as usual. Thank you so much.
Okay. Pleasure,
Thank you.
Rasha. Yeah.
Thank you. Thank you for the discussions. There's one final question here, and then I think we'll end for this evening. When we get to end-of-life discussions with our patients who have chronic kidney disease, how do we, or what are your recommendations for accommodation based on patients' level of literacy, making sure that both patients and families really do understand what the options are?
Well, I
And then
always,
also, yeah.
I will start off by asking people if they know what kidneys do.
Nice.
And if it, and then working up from there. So I'm always asking questions and then checking that they understand.
Good. Yeah, really nice and simple place to start, I guess, right? And then you go from what you know they know.
Yeah, that's right.
Well, thank you again. Dr. Lloyd, would you like to say something?
It was a wonderful session, Professor Brown. Thank you very much for coming on. You covered a lot of very important aspects, shared decision making, the cultural aspects that are involved, timing of end-of-life discussions, advanced care planning, and so on. So much of important stuff that was discussed. And I think one important thing, I don't know whether we actually capture this, stopping dialysis, the reasons for stopping dialysis. So I don't know, Erin, if we actually are capturing that. This is something I got from the session today. And we should be capturing that. Of course, economic reasons are something, but I think we should see in Africa what are the reasons, due to which people otherwise would stop dialysis voluntarily from themselves.
Yeah, very
something
important.
we don't have. Yeah. We've never been, so we've been actually, Erin has developed a whole platform of electronic data capture of all the patients that we actually see now. And so this data should be available in about a year's time. We should be able to publish it. So it's wonderful work that Erin has done, and Erin has put together this, and a big help to us. And developed a whole team now. And we've got 2 nurses in Kenya now, but a whole lot of star, champions in each center being developed. And that we hope to expand across to Rwanda and Tanzania in the next year. So thank you very much, Professor Brown. This will be on YouTube for all of us to go through again. And it will be up with all our fireside chats. Thank you so much. And I wish you a very good season, end of the year, Christmas. And we hope that you would come back to us again next year, sometime whenever you have time, just 1 hour in next year. Thank you so much.
I sincerely hope so. Yeah.
Thank you so much.